Okay, today really I'll show the techniques and the maneuvers, skills related to the general physical examination of a patient. Really in general physical examination you have first of all to introduce yourself to the patient and take a permission from him that you are going to examine him generally, and to provide him with full privacy via the curtain when a curtain is held and surrounding the patient. This is very important because this scene or this talks with the patient will provide a fertile ground for you to examine him, and I'll show you how to introduce yourself and how to take a permission from the patient. السلام عليكم. شلونك؟ شلون صحتك اليوم؟ تسمح لنا نفحصك اليوم؟ فحص عن ايديك رجليك وجهك ان شاء الله. اوكي على راحتك. Okay, really, I had taken a permission from the patient, and we have to provide him with full privacy in reality during clinical training, and especially during time of examination. You have to introduce yourself, but because our volunteer, he knows me, I didn't introduce myself for him, and we have to put in our mind that the general examination, general physical examination is conducted via two steps. First of all is the general look to the patient. Take a patient as a look, take a look at the patient as a whole, and put in your mind the following issues. First of all, the age group of the patient. How does the patient appear? This is one. Second one is the sex of the patient, awareness of the patient, whether the patient is aware, conscious, or he is lethargic, obtunded, and so on, from alteration of level of consciousness. Then the cubitus of the patient, I mean the position of the patient in the bed, and then status of comfortability, whether the patient looks comfortable or ill looking, and then body build of the patient, whether he is thin, long, or the patient is obese, and lastly you have to check whether the patient is dyspneic, tachypneic or not. This is really the general look to the patient. This should be presented together with the next step of examination, which is the regional examination. In the regional examination, I'll check the patient region by region, and you have the right to choose either topographically examine the patient from the head down to the lower limb, or you can really take first of all the hands as a region for examination, and then ascending up into the axilla, taking the head, neck, chest, abdomen, and the lower limb, as I'll perform now. I'll start with the hand. I'll choose both hands. Really, I had to take a look at the posture of both hands when the patient was in supine position. Really, the examination of the hand is as simple as that. Take a look at the dorsal surface, at the palmar surface, and then ask him to perform the maneuvers for a tremor. As simple as that. So I'll take a look at the dorsal surface, looking for any thickening, any fissure, any ulceration, the posture, color, shape of the hand, and then take a look at the nail. Okay, abnormal posture of the hand may be neurologic in origin. When the patient, for example, had, just like I'll mimic the posture, if the patient had this posture, this is what we call it claw hand. If the patient, for example, had flexion posture, this is for hemiplegia or upper motor neuron lesion. This is second posture. Third posture, the patient may have wrist drop in radial palsy. Patient may have finger drop in posterior osseous nerve palsy, and patient may also have a carpal spasm, just like this, when the patient had a flexion at the metacarpophalangeal joint and extension at the interphalangeal joint with a position of the thumb characteristic of hypocalcemia. This is the abnormal posture. And then take a look at any congenital anomaly, for example an extra finger here, we call it extradactyly or polydactyly, or there is fusion of both finger here we call it syndactyly. And if the patient had long, thin finger, we call it arachnodactyly, characteristic of Marfan syndrome. Then check the temperature. Check the temperature with your dorsal surface. This is a rule in medicine, back over back, because this side is always sweaty. And then check the nail for any nail biting, for example, that occur in eczema, in psoriasis, fungal infection. Check also the nail if they have colonychia, either flattening or concave in shape. Color of the nail, whether they are white, we call it leuconychia, or the half moon lanula that may be red, or this is really the lanula. This is the half moon shape. Proximal part is the lanula. It may be red in congestive heart failure, it may be blue in Wilson disease, hemochromatosis, and so on, from abnormality. And then check for the presence of clubbing. I'll ask the patient to perform this maneuver. بس خلينا صعب أكيد. أيوة خلينا يعني هيك. Okay, if we see here, there is a gap between the nails. This always should be present in normality. If it disappears, it indicates the presence of clubbing. The second maneuver that should be checked is to look across the radial side of the index finger. As we see here in the index finger, the middle phalanx had a depth more than the proximal phalanx and across the nail. This depth is more than this depth. This is the normal. If a patient had a depth here more than this and the ratio is more than 1, this is suggestive of clubbing, and this ratio is called phalangeal depth ratio. Depth here in clubbing will be more than the depth here. Okay, this is the first one. Second, let's take a look at the Loviband's modified sign. If we see here the distal part of the finger, this is the distal phalanx, there is an angle between the nail and the adjacent tissue. This between this nail and adjacent tissue, this angle is about 160 in normality. In patient with the clubbing, due to thickening of this part, it will be straight here and the angle will be 180. This is one. The second angle is the Kerr's modified angle between the middle phalanx and the distal phalanx. Here the angle is straight, that's to say 180 degrees. In patient with the clubbing, due to thickening of this part and proliferation of this part, the angle will reduce to less than 180. It will become of about 160. This is what we call it Kerr's modified angle, and here we call it Loviband's modified angle. This is about the examination of the clubbing. These two tests, Shamroth's test and inspection for the radial side of the finger, both these two tests are routine tests to check for clubbing because it is very important. After that, check the palmar surface of the hand for any thickening here, especially the early stages prior to fibrosis and involvement of the little and ring finger in case of Dupuytren contracture. Look also for the thickening all over in case of eczema, Naxos syndrome, and keratoderma pleonoragicum, and so on. And then hyperextend the palm of the patient to see the palmar creases as compared with your palmar creases. Because if, according to this maneuver, if the palmar creases are pale, the hemoglobin level will be less than 7. So it is as the same as me. And also look across the palmar creases, it may be black pigmented in case of Addison syndrome. Check also the other side. Don't forget to compare always with the contralateral side. And then after that, ask the patient to perform 2 maneuvers for tremor. First of all, I'll check for postural tremor, action tremor, and then for the strixes or flapping tremor. حمارة تقدر تمد لنا يديك هيجي وتفصل لنا أصابعك تقدر تستريح هنا. Okay, this is the maneuver. Just wait for a few seconds and to see if there is any oscillation just like this. This indicates tremor. If this happens, this indicates tremor. It may be fine just like this. This fine, or just like this. It is coarse. Then ask the patient to extend his wrist also for 20 to 30 seconds. You can, in Arabic, tell the patient that he should mimicking pushing something, يعني وكأنه تدفع فد حاجة هيك. After 20 seconds to 30 seconds, if no apparent tremor, you can enhance it by this maneuver. Okay, after that, if there is no tremor and we have checked the palmar surface, dorsal surface and the nails, I'll check the radial pulse. Really, you have to take an idea about the rate, about the volume and rhythm, whether regular or not, and to check the contralateral radial artery for radioradial inequality, and then the brachial artery slightly medial to the antecubital fossa using your thumb, and then check the contralateral one, and then check both brachial arteries for any inequality. After that, you have to check for the epitrochlear lymph node in the following manner. First of all, flex the forearm at the elbow joint to relax the joint here, and then slightly above the medial epicondyle here, and check the groove here. If any lymph node is enlarged, it will be palpable in this groove. Also check the contralateral one. Okay, after that, one should take a look at the lymph node in the axilla. Really, the lymph node in the axilla, this is the anterior groove, this is the posterior groove, here is the lateral groove, and here deeply, very deeply, is the central groove. Really, the examination of the axilla just like this. I'll take the patient right arm, rest it on my right arm, and I'll examine with my left hand. Likewise, here I'll take the patient's left arm, resting over my left arm, and I'll check the lymph node by my right hand. After that, really, you have to check the external surface here, especially important because this is the site of insulin and heparin, and also here to check for any ecchymosis, for example, any lipodystrophy, lipohypertrophy, or lipohypertrophy. In reality, during the clinical training, and during the clinical examination you may face or you may examine a woman. It's especially important here in our society because most our women are Muslims, so they are usually covered. Please, prior to uncovering this part of her hand, just be sure whether or not there is a cannula that is covered by clothes, because once you take off her clothes up, you may injure her, and it will be a very bad mistake for you during the time of examination. After the examination of the hand, one should also check the head, starting from the scalp, looking for the texture of the hair and for any hair loss here which suggests alopecia, and also look at the temporal recession. Presence of temporal recession in female may suggest virilization. After that, check both eyes, especially for the eye, brow, eyelashes, eyelid, and the black part of the eye, which is the cornea, and the white part, which is the sclera. Really, if we have loss of lateral 1/3 of the eye, brow, this may suggest hypothyroidism and may occur really in leprosy and so on. We have to, in the eyes, we have to check for the presence of jaundice and for the presence of anemia. Anemia is identified clinically by the presence of conjunctival pallor, and if the sclera is yellow in color, one should consider jaundice. Really, the examination, when you examine for anemia and jaundice, simultaneously examine for them and ask the patient to direct his face into the natural light, which is usually obtained through the window. If we suppose that the time now is daytime and the curtain is pulled apart and natural light is obtained, I'll ask the patient to turn his face toward that side. Okay, after he had turned his head, I'll check for the presence of jaundice in the following manner. I'll ask the patient to follow my finger. هسه بس باوع اصبعي ورا اصبعي. Okay, if we see here both sclera are visible, we can detect whether there is yellowish discoloration or not. After that, I'll ask the patient to follow my hand up, and I'll press to see the conjunctiva. باوع على ايدي. Okay, the other one. Also, after that, I'll check both cornea for arcus lepidus and also for KF rings, and for the pupil size, whether they are narrowed or constricted, or they are dilated, or they are irregular in shape. This really with respect to the examination of the eye. After that, I'll check the external ear, really check for any abnormality, tenderness here at the tragus, and check for any discharge. Also, in the same manner, I'll check the other eye or the other ear for any abnormality. I'll press for tenderness in case of infection, and I'll see the external auditory meatus. After that, I'll take a look at the nose, seeing in particular the septum, ele nasi, and look for any discharge or nasal polyp. Really, here loss of some part of the symptom, depression here, indicates saddle nose that may occur in relapsing polychondritis, Wegener's, and in leprosy, and also in many other clinical conditions. After that, I'll check the mouth. First of all, I'll inspect the mouth for any deviation in the resting state. After that, I'll ask the patient to open his mouth. Because sometimes the opening is so restricted in case of microstomia and typified the clinical of scleroderma. After that I'll see the tongue inside the mouth in the resting state. بس فتح نحلقك حماد. For any fasciculation. Okay, after that I'll check the lips, both inner border and outer border, the cornea, the corners of the mouth, and also the upper lips for any ulceration or infection. After that really I'll use a torch for the internal aspect of the mouth. فتحنا بعد حلقك حماد. For the presence of any dental caries, for high arched palate in case of Marfan, and for the presence of infection. After that I'll ask the patient to raise his tongue. ارفع لنا لسانك. To see the sublingual tissue. This is the sublingual tissue. على راحتك. Really, after that you complete the examination. After you complete the examination of the mouth, you have to put in your mind that the sublingual tissue may be discolored, yellow in case of jaundice, may be pale in case of anemia, and it may be involved in case of cyanosis. Cyanosis here, if it involves the tongue plus the sublingual mucosa with the involvement of the lips, this is most likely central, especially if it is accompanied by digital clubbing or warm hands. If the hands are cold, the extremities as a whole are cold, and there is no involvement of the tongue, one should expect that the patient had peripheral cyanosis. Really, if the patient had combination of both, that's to say, the patient had clubbing, for example, but the extremities are cold with no involvement of the tongue, one should comment on this, that there is a central and peripheral cyanosis. In reality, the candidate should also know about other types of cyanosis, which may the examination committee ask him about, including the differential cyanosis and acrocyanosis. The next step in the general examination after the head is the examination of the neck. Really, in the examination of the neck, you have to put in your mind the following structures. First of all, you have to detect the trachea, whether it's central or slightly deviated to any side. And then you have to check for the thyroid. After that, you have to check for lymphadenopathy, lymph nodes of the head and neck. And after that, for the vasculature of the neck. In addition to that, you have to see the contour of the neck. For example, short-webbed neck may occur in patient with Turner syndrome, and long neck may be a manifestation of Marfan syndrome. In the examination, first of all, in the examination of the trachea, you have one of the following two procedure or maneuver. First of all, you have to introduce the left index, the right index finger over the suprasternal notch, exactly in the midline. You will feel the trachea, which is central and or slightly deviated to the right. This is the first maneuver. The second maneuver, you can use three middle finger by placing the index finger and ring finger over the attachment of the sternocleidomastoid with the sternum, and the middle finger is pressed into the middle to feel for the trachea. The trachea, as I said, should be central. This is for the trachea. After that, you have to ask the patient to swallow to see any thyroid enlargement. بس تبلع لنا ريقك حماده. Okay, all this about the thyroid and the trachea. After that, you have to check for lymph node in the following group. First of all, the submental group, submandibular group, pre-auricular, post-auricular, occipital group, here posterior cervical. Anteriorly, we have in addition the tonsillar lymph node, superficial cervical, deep cervical, scalene lymph node, and in the supraclavicular fossa you have to check for the supraclavicular lymph node. Really, in the examination we have two steps. First of all, I'll examine anteriorly, and then posteriorly. بس حماد تقدر تقعد لنا بس أصير وراك يعني أصير ورا ظهرك. Okay, I'll check the following group as I said. First of all, you have bilaterally to check the submental and then submandibular group, pre-auricular group, post-auricular group, occipital group, also bilaterally. And then we have to examine the anterior neck. Really, in the examination of the neck vessel, you have to tilt the patient to the side of examination, and it's preferable to examine just one side. First of all, the tonsillar, and then superficial cervical, deep cervical, and then for the scalene lymph node in the following maneuver, you have to press the index finger between the sternocleidomastoid and the clavicle in the following way. In such a way, you have to search for lymph node, and then also you have to check the other side, tonsillar, superficial cervical, deep cervical, and for the scalene lymph node. After that, I'll ask the patient to shrug his shoulder for the supraclavicular fossa to be more obvious. حماده بس تجنح هيك خفيف وايديك لقدام شويه. Okay, this is the supraclavicular fossa, so you can palpate here for any lymph node. هاي عشت ايدك. After that, I'll check the posterior lymph node from the front. بس علي هسه ما عين عادل. عشت ايدك. Okay, I'll check the posterior cervical, the occipital lymph node, and the post-auricular lymph node. Okay, على راحتك. Really, if you find a lymph node, you have to determine first whether this lymph node is a normal finding or it is an abnormal finding. Normal finding really when a person, healthy person, may have a lymph node that is less than 1 cm, and especially in the submental, in the submandibular area, or sometimes in the inguinal area may reach up to 2 cm, which is normal. Anyhow, when you find a lymph node, you have to detect the following characteristics of that lymph node. First of all, you have to detect the size of the lymph node, position, I mean the site of the lymph node, attachment, whether the lymph node is attached to the underlying muscles, for example, overlying skin or subcutaneous tissue and so on. And then you have to detect the consistency of the lymph node, whether it is hard, firm, soft. And then you have to detect the other characteristic of lymph node, for example, delimitation, for example, if the lymph node are matted together in case of tuberculosis, or they are desecrated and symmetrical in case, for example, of lymphoma. And then you have to detect the shape of the lymph node, whether they are ovoid in shape and spherical in shape and so on. In addition to that, really, and the most important thing is to know the sign and the sign of the detection of the supraclavicular lymph node, and what is the name of supraclavicular lymph node if it is get enlarged from the metastasis. Really, we call them the virtuous lymph node, and its sign we call it the Trozer sign. All these issues and aspects are about the lymph node examination of the neck. Okay, the next step and the last step in the examination of the neck is about to examine or check the vasculature of the neck in the form of carotid arteries and jugular veins. Let's take a look. First of all, we have to let's determine the carotid pulsation, really by pressing here laterally with the left thumb over the transverse spinous processes of the neck. You will see and you will feel the pulsation of the carotid. After that, you have to detect the contralateral side, just like this. do not compare both sides simultaneously. This may induce syncope. After that, we have to check for the jugular veins. First of all, we have to make the patient neck relaxed. If we have a look here in the neck, we have to know that we have here carotid artery and jugular veins, both internal and external jugular vein. First of all, make the head of the bed at 45 degrees from the horizon. If the patient had no visible veins, just like our volunteer here, you have to lower the head of the bed down. If the patient had elevated jugular vein well above the mandible, you have to ask the patient to even sit. This is first. After that, we have to inspect the pulsation in the neck to determine whether it is arterial or venous. Really, the venous had two peaks per beat, while the arterial had one. The most prominent movement in venous pulsation is inward, while it is outward in carotid pulsation. After that, you have to palpate the left carotid of the patient and to see whether what you see here from pulsation, is it comes or coincide with the pulsation felt here. If it is so, it is arterial, otherwise it is venous. And when we would like to determine the venous pulsation here, between the clavicular and the sternal head here of the sternocleidomastoid, the internal jugular vein will appear from here and ascend till here. Really, this is the jugular venous pulsation, will be visible here. Lateral to it is the external jugular pulsation. If you are able to see the internal jugular pulsation, you have to take it as a measurement for the JVP. Otherwise, you can use the external jugular pulsation. Once you detect venous pulsation here, try to palpate it. If it is palpable, so it is arterial. If it is not palpable, it is venous. This is one of the maneuvers. After that, you have to obliterate at the neck root. You have to obliterate the pulsation, just like this. And to see whether the pulsation is obliterated or not. If it is not, so it is arterial. After that, you have to ask the patient for the cosmal sign to take breathe and take it and out. هذا هسه تاخذ نفس قوي. هاي يقطع. ذبة قوي. اقطع. Normally, على راحتك. Normally, the jugular venous pressure will be elevated during expiration and lower during inspiration. The reverse is called the cosmal sign. After that, we have to warn the patient and tell him that we are going to perform the abdominal jugular reflex. بس حماد راح اضغط شوية على بطنه. While we inspect the jugular venous pressure here, we have to press the mid-abdomen with our palm. Thumb pressure for 10 seconds and to see the jugular venous pressure for 10 seconds, and then remove your hands. If the jugular venous pressure is raised and then descend 4 cm with the withdrawal of the hand, this indicates positive abdominal jugular reflex. This test is designated to check the right side function of the heart. After that, we have to determine the upper limit of the jugular vein. For example, if it is here, let's say, if it is here, how can we determine it? We can determine it. This is the top of the oscillation or of the pulsation, and you have to have a ruler from the sternal angle. Sternal angle is about 5 cm below the suprasternal notch. Here, a ruler, and to check. For example, if it is here, so it is about 5 cm from the sternal angle. You can comment upon the JVP that it is 5 cm above the sternal angle, or totally it is 10. Why? Because from the right side of the heart till the sternal angle we usually give fixed value, which is 5 cm. So 5 cm plus this 5 cm, the net result will be 10 cm water, which is the JVP. After that you have to check the jugular veins, which wave is apparent. Normally the A and V wave is the or are the most obvious one, and we have to know the waves, how we can draw the waves of the JVP. Really we have a simple skills here. First of all, we can write C V A. Really this term is widely used in neuromedicine, but here it indicates the waves of the jugular vein, some of the waves. Between them you can put here X and here Y. Just connect between them. This is the jugular venous pressure. Then you have to determine which wave or what are the waves that coincide with the systolic phase and what other waves that coincide with the diastolic phase. Really we can, if we put an imaginary lines here, this is the systole, the other occurs or the other occur in diastole. How we keep them in our mind? X, C and S for systole, all of them contain the pronunciation S. So C wave, X wave occur in systolic phase, while the V, Y and A occur in diastolic phase. This is really about the how to draw or how to sketch the JVP waves. After that you have to know the causes of the jugular venous increased jugular venous pressure in general. You have to know the causes of giant prominent A wave or the canon A waves, the causes of V wave, most prominent V wave in the jugular vein, and X and Y, prominence of X and Y, for example in constrictive pericarditis, or just the Y with the absence of X, for example in patient with cardiac tamponade. And also you have to know the causes of the cosmal sign. All these about the examination of the jugular vein in the neck. After that you have to check the chest and the abdomen and lower limb. Really in the chest, specifically look at the upper chest, and as always you have to excuse from the patient for that, especially if the cases of alternative sex, especially if the examiner is male and the patient is female. Specifically look at the upper chest for the presence of, for example, for spider telangiectasia, if the patient had gynecomastia or not, and look here for double lumen, that of uremia and pacemaker here in patient with the cardiac problem, and so on, of diseases, primary and secondary skin lesion. Also take a look at the abdomen and see whether the abdomen is distended or not. Really here you are in the chest, we have the breast can be examined, precordium and the respiratory system can be examined. Really the respiratory system and the precordium are systematic examination, and we will defer them into a special situation. And the for examination of the gynecomastia or examination of the breast, this is a specific examination and it is examined separately. Likewise the examination of the abdomen is also system examination and examined separately, so you can satisfy with these measures. After that take a look at the leg. What we have learned in the upper limbs you have can be applied in the lower limb, taking into account the outer surface and the inner surface and the outer surface. Also look at the dorsum of the legs and then detect the dorsalis pedis artery between the first two metatarsal bones, and then anterior tibial artery between the two malleoli, and then the posterior tibial artery between the medial end of the Achilles and the medial malleoli. Likewise you have to detect patency of this vessel in the contralateral leg also. After that you have to check for nail abnormality that are the same as what we have learned in the upper arms. After that, detect between the toes webs for fissure, ulceration, infection, and so on, and look at the plantar surfaces bilaterally, and also palpate the plantar surfaces. After that, you have to detect for edema. How can we examine for edema? First of all, look at both legs for any obvious swelling, and then press over upon a prominence, for example over the shin, just like this, by your thumbs, and your face should be directed to the patient's face to determine whether there is any tenderness or not for a few seconds. After that, determine the edema, if any, whether it is bitting or non-bitting. If there is edema, one should comment upon it in such a way that the patient had bilateral edema or unilateral. If it is bilateral, you have to detect whether it is symmetrical or asymmetrical. And both you have to detect whether it is tender or non-tender. And in addition to that, you have to determine its grade and its level. How can we determine its grade? The grade of edema is determined in such a way: when you press and then remove your finger, how much the indentation spent from the time till it returned back into its normal state. And this grade subjective by the examiner and could be from +1 into +4 in patient with severe edema. Its level, how can we determine it? You can, after pressing here, you can press at the upper leg and the upper shin also, and detect the level up to the abdomen. This is all about the level of the edema and edema in general. After that, you have to keep in your mind that in all the examination, during all the general examination, you have to detect whether the patient had a primary skin lesion, secondary skin lesion, and medical accessories. Medical accessories may take the form of cannula, oxygen mask, or the patient had giving set with the fluid, with the blood, and so on from medical accessories. Primary skin lesion may take the form of macule, papule, and so on. Secondary skin lesion may take the form of ulceration and so on. You have to read about them carefully, and never forget when you present the case and when you examine the case, these two steps of general examination, that are the general look at the patient, should contain age group of the patient, sex of the patient, awareness of the patient, the cubitus of the patient, that's to say position of the patient on the bed, the comfortability of the patient, whether the patient is comfortable or not, body build, and lastly whether the patient is dyspneic or tachypneic. This is about the general look at the patient, while the regional examination should contain jaundice, anemia, cyanosis, clubbing, edema, and lymphadenopathy. All these issues and scales required for the general examination, and I am greatly thankful for your listening.